So this is number 4. So we discussed together. Tell me if you cannot hear or anything. I'll just put in the side the chat group. So let's go for the first case. Okay. So what do you think this is? What is this ceiling?
I don't know about TEE.
I know you don't know about TE, but what is this? What is this structure here? That's the left atrial appendage. So that's the left atrial appendage. Okay. So this is actually TE view because you know that we can only see clear left atrial appendage on TE. TTE is difficult, so we can never rule out clots from transthoracic echo. So this is transesophageal echo. So when we do TE and look for LAA clot, we have to go through all the plane. We have to go to 0 degree, 45 degree, 90 degree, and 120 degree. So that is the plane ceiling. So once you start cardio or you come to IGN, I will show you what is that. And then you can see, and then you have to make sure that there is no clot in all of the view before you do cardioversion. Okay, just guess, what is this inside here, Sarah?
Clot?
Nope. That is not clot. What is that? Something that we always confuse with clot. That is the pectinate muscle inside the left atrial appendage. They have a pectinate muscle. So that's the pectinate muscle there. So don't confuse the pectinate muscle with the clot. The pectinate muscle is actually very important structure to define whether you are looking at left atrium or right atrium. So in left atrium, the pectinate muscle will extend all the way out of the right atrial appendage. So if you see appendage that have pectinate muscle outside of the appendage, then this is a morphological right atrium. So morphological left atrium, the pectinate don't go out. And then for left atrium, furthermore, the appendage is narrow and it is like a finger-like projection. So there is few different type of left atrial appendage basically. So because we know that left atrial appendage is associated with stroke. So the 4 different type of left atrial appendage is quite difficult to see. I also struggle, but just for you to remember, there's 4 type and it is actually fruit. So chicken wings, cauliflower, or broccoli, so that's the same, cactus, and also windsock. Okay, so 4 type of left atrial appendage. So chicken wing, cauliflower or broccoli, and then windsock, and also cactus. So, I mean, the only thing that I think sort of important to remember is whether it is chicken wing or non-chicken wing. The reason being the non-chicken wings have much higher risk of developing stroke compared to chicken wings. But this is how it looks. Okay, I don't know whether you can remember or not. So basically, what do you think this one? Look like what? Cactus? Chicken wings, windsock, or cauliflower? Guess.
Cactus.
Cauliflower.
Yeah, okay, so both of you are correct. So this is actually broccoli or cauliflower. Okay, so this is how it looks like. So that's how broccoli and cauliflower looks like in transesophageal.
It looks rather big, huh?
Indeed, because this, I think, when you different in what view you see, what view you see. I think if you do a 120 degree view, it's always quite big. So I think this is 120 degree view, if I'm not mistaken. But this is how the cactus look like. You can see that the odds ratio for CVA is 8. So, but not statistically different compared to the other left atrial appendage. But you can see the next one. So what do you think? So this is another left atrial appendage. Okay, let's ask Saravanan. What is this thing? 1, 2, 3, 4.
That is pectinate muscle.
Yeah. So this is pectinate muscle. Okay, that's pectinate muscle there. So this is another type of left atrial appendage. What do you think?
Cactus.
This is a chicken wing.
So this is cactus. Okay. So this is cactus.
Cactus.
Okay. So basically, both cactus and cauliflowers, all their risk of stroke is higher than chicken wing. So that's cactus. Okay. So just I don't know, it's like a pattern recognition. When we learn about left bundle branch block, right bundle branch block, right? I can never describe them. I can only remember the look only. So this is cactus. Okay. So this is 4 different types of LA appendage. Okay. So from here to here. So this is in TEE. This is in CT scan. This is in an angiogram. This is a CT scan cast. Okay. So let's guess one by one. Okay. What do you think this is?
Cactus.
Cactus. Okay. Sarah, agree?
Yeah.
Okay. What is?
That is.
Remember the 4 different one?
Yeah.
Cactus. Cauliflower, windsock,
That one was
and chicken wing.
windsock.
So this is windsock.
Windsock.
Okay, this one.
Cactus.
Okay, this
Cactus.
one.
Chicken wing.
Yeah, this
Doesn't
is.
look like chicken wing.
I know exactly. So this is chicken wing. So you're right. So that one is cauliflower. Okay, I think it's quite easy to differentiate. I think the problem is between cauliflower and cactus, I think. Right? So windsock and chicken wing is quite easy, but cauliflowers and cactus is a bit weird. Yeah, but anyhow, this is what I wanted to show you, just so that at least you are familiar, so that you won't laugh and suddenly people are giving talk about cactus type left atrial appendage or chicken wing type. It does exist. Okay, it does exist.
Okay.
Okay, look at this. This is a parasternal long axis view of an echocardiogram. Okay, look properly. Okay, so that's parasternal long axis view. So maybe I play it 3 times because I know that it is very jerky when you look at it. Okay, so parasternal long axis view. Okay, so I think I run few times already. Okay, so this is color flow of that parasternal long axis view. Okay, so this patient have mitral regurgitation. Okay, so just looking back at the parasternal long axis view, okay, what do you think is the etiology of the mitral regurgitation?
The PMVL is immobile or
The PMBL is restricted, correct? So the jet is directed posteriorly.
posteriorly.
So looking at that echo, what is you think the most likely diagnosis for this type of MR?
Prolapse AMVL.
No, if let's say if it's a prolapse PMVL, where will the jet be directed?
Yeah.
The jet will be directed
Opposite.
opposite direction, right? So it will be directed anteriorly. But this one, the jet is directed posteriorly. So what do you think? Looking at this echocardiogram diagnosis. Okay, first is this
Ischemic MR.
Yep, it is ischemic MR. How can you tell this is ischemic MR, Saravan?
There's a bit of hypokinesia in the
Very good.
basal inferior.
What is this called?
Basal
Basal what?
inferior wall.
Yep, this is what we call basal inferolateral wall. Okay, so it's important for you to remember the name of the wall. Okay, that is basal inferolateral. Can you see that this is hypokinetic or not? Do you both agree that this is hypokinetic? Ceiling, really?
Yeah.
So that's hypokinetic here. So this is the typical definition of ischemic MR. So it is a regional wall motion abnormality isolated to the inferior wall or the regional wall motion abnormality of RCA. It causes tethering and tenting of both leaflet, but affect the posterior leaflet more because the posterior leaflet is shorter and therefore more restricted, and the jet is directed posteriorly. The ejection fraction is usually not worse than 35%. Once it goes worse than 35% and start having global hypokinesia, regardless of whether it is coronary artery disease or not, then it has become dilated cardiomyopathy. This is sort of a different subset of functional MR. Celine, what is the name of the segment of the wall here? So what is this?
Anterior septal.
Yes, good. Whenever you see, it's easy to remember. Okay, the way to remember is like remember 3 segments. Remember basal, mid, and apex. So anytime you comment echo segment, is always either basal, either mid, or either apical. So, and then if we wanted to think whether there is a septal involved, always look at the side. If they say you can see a right ventricle at the side, so that's always a septal wall. So this part is both basal and this part is both mid. Okay, so the other difference is this is basal inferolateral. You know that this is basal antero but septal. So mid anteroseptal, and this is mid inferolateral. So this is where LAD, this can be either RCA or circumflex artery. So you can see that the jet is directed posteriorly. So this is ischemic mitral regurgitation. So this is a concept called proportionate or disproportionate MR. So have you heard about that concept before?
You mentioned before.
Yep. So can you tell me the difference between proportionate and disproportionate MR?
The severity of the MR in relation to the LV dilatation.
Very good. So which one is proportionate, which one is disproportionate?
Proportionate means MR is severe and LV is dilated.
Very good. And disproportionate is the other one lah. Okay. So which one is more likely to recover with, say, the MR will likely to be recovered with either revascularization or mitral clip procedure? Is it proportionate or disproportionate?
Proportionate.
No. It is disproportionate MR. Okay. So what you say is correct. So proportionate MR in when the MR is directly proportionate to the severity of the LV dilatation. So usually the MR is the LV dilatation is not so severe, but the MR is, like sort of follow. So the MR is actually like a bystander to the LV dilatation. So if you see someone with severe MR, but and also the LV is very dilated, okay, so that is a proportionate MR. In disproportionate MR, the MR is severe, but the LV is not so dilated. So in disproportionate MR, the MR is actually play an active part in the propagation of the mitral regurgitation. So MR beget more MR. So MR cause LV remodeling, cause MR again, cause LV remodeling, cause MR again. So that's disproportionate MR. So that's, the two trials called COAP and MITRA FR. These two trials try to see in a randomized fashion whether comparing mitral clip to medical therapy for functional MR, whether there is improvement in mortality. So we know from previous study in terms of secondary mitral regurgitation that no study have shown mortality benefit, if you do mitral valve repair or replacement in patient with ischemic mitral regurgitation. So doesn't matter if you repair, replace, or leave it alone, you won't affect the mortality. So MITRA clip, MITRA FR and COAP trial actually look at the this phenomenon and in a randomized manner. So it's very strong trial looking at patient with functional MR compare medical therapy and MITRA clip. So when MITRA FR was published a month earlier, they showed that there is no benefit. So people sort of expected that. They said, okay, secondary MR, sure, there is no effect on mortality. But when COAP trial was published a month later, so MITRA FR is a French study, COAP is a US study, and suddenly there is very, very a lot of benefit. So people was a bit surprised because how come both trials that looking at the same problem have different, very drastic different in results. And when they look at the study, they see that in patient in COAP trial, most of the time the LV is smaller and the MR is more severe. And both of the MITRA FR, the MR is not as severe, but the LV is very dilated. So when they do a sub-analysis of a MITRA FR patient in which the patient have disproportionate MR, they see exactly the same benefit as the COAP trial. So now we know that. So they say in patient that the LV is not so dilated, but they have severe MR, intervention such as MITRA clip is very good. Do you think you get it, Sarah? Silik?
I think so.
Sarah?
So they don't do. I mean the mitral clip, does it revascularize?
No, they just do mitral clip only.
Okay.
Sarah, okay.
So that means the proportionate MR will it's better to use mitral clip lah.
No. Disproportionate MR have benefit if you use mitral clip, not proportionate. Disproportionate. Because in disproportionate...
But just now you said the mitral MR trial shows that disproportionate MR in that group mainly.
Okay, so when they look, so basically COAP trial is a positive trial. So MITRA FR trial is a negative trial, okay? At first, they thought that these two studies looking at the same population. But when they look properly at the patient that is enrolled in MITRA FR, most of the patient have proportionate MR, meaning that the LV is very dilated, okay, compared to the MR. But when they look at COAP, so they see that the COAP, a lot of them has disproportionate MR. The MR is severe, but the LV is not so dilated. Okay, so fine. Okay, they say that's why COAP have positive result. And furthermore, when they look back at the MITRA FR trial, even though MITRA FR mostly is proportionate MR, there is small population that is disproportionate MR. And when they do sub-analysis of this disproportionate MR in MITRA FR, they also have the same benefit as what's seen in COAP trial, further strengthening the argument that disproportionate MR derive better benefit from mitral clip. Clear or not, Sarah?
Yeah. What kind of MR is disproportionate MR?
Usually, ischemic MR tend to be disproportionate because you remember the definition of ischemic MR, EF that is preserved more than 35%. Okay, so LV is not so bad. So mostly it's an ischemic MR.
But ischemic MR also will improve with revascularization, right?
Correct. So that's why what you can do in terms of practical purposes is you can do revascularization. Let's say you see someone with severe ischemic MR, right? So what you can do is you can do sort of like a hybrid procedure. So you can either do a PCI, you wait. If let's say the MR doesn't recover, you do mitral clip. So that's one way. The other one is do PCI and mitral clip together. Another one is someone that you see the coronary, okay, maybe they have coronary artery disease, but there is nothing to revascularize, okay, or they are not fit for surgery for revascularization. Then you can straight away go for mitral clip. Make sense? Sarah? Sarah is very slow.
Yeah. If you do PCI after revise, how long?
Usually we can look, I think it's about 3 to 6 months.
Hello?
Yes, I can hear you. Yep, I can hear you. Sarah, I can hear you. I can hear you.
Okay.
Celine, you can hear me?
Yeah, can.
Okay, Sarah, I can hear you.
Internet.
Oh, okay. So that is ischemic MR. Okay, like maybe we go to the next case. Maybe the internet will
I think I
get
have to
better.
go to downstairs. Okay.
Okay, sure. I'll later you come back. So what is the most likely etiology of MR? So this is actually ischemic mitral regurgitation. Okay, so Celine, you understand, right? All right.
Yes, I think.
So this is another cases. So this is a parasternal long axis view. So you can see the left atrium and the left ventricle there. Okay, so see one more time. Okay. All right. That's the left atrium and left ventricle. So that is also look like a severe mitral regurgitation. Okay, look at severe mitral regurgitation. Okay, the jet is directed posteriorly. Okay, looking back at parasternal long axis. Okay, just look at the color view and look back at parasternal long axis view. All right. So what do you think of the etiology of this mitral regurgitation?
I think there is prolapse AMVL.
Yep, that is, I think, one of what that's very fair. I think prolapse of anterior mitral valve leaflet is very fair. It's possible if there is prolapse of anterior mitral valve leaflet. Okay, if let's say the anterior mitral valve leaflet is not prolapse, but you see this kind of MR, what other differential diagnosis apart from prolapse of anterior mitral valve leaflet?
Posteriorly directed is either ischemic or the primary valve problem.
So it can, you're correct. So it's either primary valve problem, such as myxomatous, leaflet flail and stuff. It's also secondary. So secondary can be LV dilatation or ischemic MR, correct? So which one do you think this is? Is Sarah back? Sarah?
LA dilatation.
Yes, yeah. Correct. Another reason is patient with LA dilatation. Okay, so what kind of MR you think that is caused by LA dilatation? What can cause LA? Yeah, secondary. What can cause LA dilatation? What is atrial fibrillation? So you know that chronic atrial fibrillation, that can cause tricuspid regurgitation, right? By causing tricuspid annular dilatation. So Saravanan, why AF more commonly cause tricuspid regurgitation compared to mitral regurgitation?
Because of the what we call?
Why?
Pacemaker?
No. Why in patient with AF they are more likely to have tricuspid regurgitation rather than mitral regurgitation?
Because mitral, the annulus is more fibrous.
Very good. Right? You see that the mitral valve, the annulus is made of fibrous tissue. You see tricuspid valve, the annulus is just the atrial wall. So that's why TR is more common with atrial fibrillation. So what is this called, Sarah? AF that causing mitral regurgitation? This is a very tough question. What does AF causing mitral regurgitation call?
What does again? Sorry.
Okay, what is this entity called in which AF cause MR? It's very, very difficult question.
AFMR.
Yeah, it is called AFMR. AFMR. Right. So this is an Sarah, you heard that before, right? Atrial functional MR.
No, functional MR, yes, but atrial functional MR.
So the MR is divided into primary or secondary. So secondary can be either ischemic is one, number 2 is dilated cardiomyopathy, but we have another one. It is not new, maybe 5 or 10 years, entity called AFMR, atrial functional MR. So what happened is that you have chronic atrial fibrillation, caused LA dilatation. Okay, so when you have LA dilatation, of course, it causes annular dilatation. So there is less coaptation. That's one. Another reason is that this posterior leaflet, as the LA is dilated, the posterior leaflet is displaced like so. So it's sort of displaced, posterior leaflet displaced to the back like that. Okay, displaced to the back like that. So this is atrial functional mitral regurgitation, AFMR. So I see quite a few AFMR, atrial functional mitral regurgitation. So I hope you remember that. So this is an example of AFMR. So ceiling said anterior prolapse, and I think that's very fair. You can see a bit of prolapse anteriorly, and jet is directed posteriorly.
However, can I ask something?
Can.
Is it common to have, I mean, how much of LA dilatation can happen in AF normally?
A lot. Can be big, can be giant also. No problem. Also possible. Like this one is like basically just from AF. This LA dilatation is just from AF. What do you comment about the left ventricle? Okay, let's ask you whether you remember. What is the name of the segment here?
Inferolateral.
What type? Remember when I tell you always basal, mid, apical. So basal what?
Basal inferolateral.
Very good. This one?
Basal anteroseptal.
Yeah, because you see the right ventricle. Okay, the LV's function is okay, and there's no regional wall motion abnormalities. Okay, so this is.
Yes. Sorry, can I? The atrial functional MR is a subset of secondary MR, right?
Correct.
Or subset of a functional MR.
No, secondary MR. Functional MR is secondary MR. So functional MR and
it
secondary
is not
MR
under
is
like a.
Okay.
Now do we divide the secondary MR into functional, atrial functional, and
yes. No, that's the problem. Okay, that's the problem. I also say problem. This is just your. I think this is a semantic problem. So let's say if you ask me, I would like do like this one. So this is gonna be secondary MR. Okay, then one gonna be primary, and then secondary MR I will be divided into functional MR. So functional MR and dilated cardiomyopathy will be one group. Then ischemic MR will be one group, and then AFMR will be one group. Is that okay? So you call them primary MR, you call them secondary MR. Under the banner of secondary MR, you divide into this functional or dilated, which is the same, ischemic and AFMR. Is it better like that, you think?
Yeah,
that's better like that. Right? So we call primary, secondary, and then we do like this. So I think maybe from now onwards we do like that. To be honest with you, it is very, it is very difficult because some people will just say functional MR when they mean ischemic MR. So, and that's the reason a lot of trial on secondary MR is unsuccessful because they didn't divide properly. So everything they lump into secondary MR, like patient in MITRA FR. So that's why their study doesn't happen, does not yield a good result. So this is atrial functional MR. All right. So this is an apical four-chamber view. Okay, so that is LA, RA. So LV, there's RV there. Okay. So how do I know that this is the right ventricle, Saravan?
Trabeculars.
Yes, the right ventriculation have coarse trabeculation. Some more. Just looking at this echo.
Insertion of the tricuspid valve.
Very good. So the insertion of tricuspid valve is apical to the insertion of the mitral valve. So that's one. Then what number two? What is this?
And then
moderator band there, right? That's moderator band. So moderator band, that is all structure of the right ventricle. That's why we know that this is the right ventricle. So whenever we want to see this right ventricle, so that is one. So what other things about right ventricle? What about the leaflet? What is the thing that is unique about the chordae of the tricuspid valve, Sarah?
Chordae of the tricuspid valve. It is attached directly to the valve.
Three chordae.
All chordae attached to the valve. So the attachment of the chordae, you are correct. So chordae normally attached to the papillary muscle, right? But there's something special about tricuspid valve. The chordae attached directly to the septum. Okay, some of the chordae attached directly to the septum. So you have the anterior leaflet attached to anterior and posterior papillary muscle. Posterior leaflet attached to the posterior and septal papillary muscle. But septal leaflet is attached to the septal papillary muscle and also directly to the septum. So in normal situation, the left mitral valve is not attached to the septum. It's only attached to the papillary muscle. So that's the difference between the two. Okay, so whenever you look at echo, the definition of the cavity is not by their special location, but their characteristic. But of course, in adult, it's very, you assume that, all is okay. But when you look at the congenital, especially you are interested in congenital heart disease, you have to ask yourself, is it really right ventricle? Is this really left ventricle? Is this really left atrium? And is really right atrium? So we have talked about this now. So is there any abnormalities you see from this echo? See?
The right heart is very dilated.
So right heart is very dilated. So you have to, answer a question, why is your right heart is dilated? So how do we approach right heart dilatation?
To determine whether is it pressure or volume overload.
Very good. Whether it's pressure or volume overload. So continue.
And to find the cause of it.
Yeah, very good. I mean, so is it pressure overload? Look at the TR. Is it a leaflet problem?
TR
So
max.
yeah, so unlikely to be a leaflet problem. The leaflet looks okay here. Let's look at next echo. Okay, this is a subcostal 4-chamber view. So LA, LV, RA, and RV. So look at the right side. Okay, again, what do you think about this segment there? Does that look normal to you? The right ventricle wall. What do you think, Sarah?
Yeah, not normal.
So how do you describe this?
Hyperdense.
That's like a bit of aneurysmal,
Increased density.
Yeah, that is a bit aneurysmal, right? It's not straight. You can see rounded structure there, rounded. So the RV is dilated, and it's also aneurysmal. So whenever you have a combination of regional aneurysm and dilatation of RV, right? So this is another case. Right? See again, this is RV. Look at the apical part of the RV. Also aneurysmal, and it's also dilated. Okay. So what is your differential diagnosis in this situation? Where you have regional aneurysm plus dilatation of RV.
RV infarct.
Okay, one is possibility RV infarct. What if, let's say, in ACG, you can see epsilon wave?
AVRT.
Yes, this is arrhythmogenic right ventricular cardiomyopathy. Okay, so that's the echo 3 patient with the same diagnosis. So this is arrhythmogenic right ventricular cardiomyopathy. I think the thing that point you toward that diagnosis is because a lot of things can cause RV dilatation. But if you see localized aneurysm, that is quite rare in the right side of the heart. So always think about arrhythmogenic right ventricular cardiomyopathy. So this is an example of ARVC. So we change it from dysplasia to cardiomyopathy because when they look at the pathology, there is no dysplastic myocardium. The myocardium is not dysplastic. So that's why they change it from dysplasia to cardiomyopathy. So it can actually involve the both ventricle, and the important criteria in ARVC is regional wall motion abnormalities or aneurysm and RV dilatation in the absence of other explanation. The ARVC, we have patient with hypertrophic cardiomyopathy, and we advise them saying that don't exercise, right, because you have a risk of sudden death. But until now, we don't know actually in HOCM whether exercise increase the risk of sudden death. Okay, we don't know that. Okay, we just do and assume patient that have HOCM cannot go for competitive sport. This is completely opposite of ARVC. ARVC, we know that exercise objectively make ARVC worse, and exercise objectively make the risk of sudden death worse in ARVC. So patient with ARVC, you have to really advise against competitive sport or even big exertion. So this is a criteria for diagnosis of arrhythmogenic right ventricular cardiomyopathy. So as you can see, the criteria is always a combination of regional wall motion abnormalities plus RV dilatation. Okay, if you have someone with regional wall motion plus RV dilatation, and you cannot find other cause, always think about arrhythmogenic right ventricular cardiomyopathy. Okay, regional plus RV dilatation. So this is a number.
It must be accompanied with ECG changes, right?
No, the ECG is not necessary. So the problem is epsilon wave, even though it is specific, it is not sensitive. A lot of patients with ARVC don't have epsilon wave in the ECG.
Oh, okay.
All right. So this is another example of someone. So this is a apical long axis view. Okay. So that's apical long axis view. So that's LA there. That is LV, LA, pulmonary artery, aorta. Okay. So look at it. Okay, look at this. That's another view here. Okay, so now the one that I do a border, so that is aorta on top there. Okay, so here is pulmonary artery, aorta, LA, LV, aorta, pulmonary artery. Okay.
Where's the pulmonary artery?
Okay, one more time. So this is pulmonary artery here. So because it's not clear, I show you the border. So the one in the border here is aorta. Below here is pulmonary artery. Okay. So aorta, that's pulmonary artery. Okay. So now, what is your diagnosis? Look at this back. Okay. Look at this picture here. What is wrong with this picture? So this is LA, LV, pulmonary artery, aorta.
TGA.
Okay, so this is transposition of great artery. Okay, why is transposition of great artery, Sarah?
Because the aorta is anteriorly and leftward.
Okay, not in this situation. This situation, aorta is anterior and rightward. So this pulmonary artery, this aorta. So that's anterior, so anterior and rightward. What about the connection? So you have a left atrium connect to the left ventricle. So there is atrioventricular concordant. But left ventricle is actually connected to what here?
Pulmonary
So
artery.
left ventricle is connected to pulmonary artery. So you have VA discordant. So you have AV concordant and you have VA discordant. Whenever you have AV concordant and VA discordant, this is called what kind of TGA?
CCTGA.
Nope. Okay. So there is two.
No. This DTGA.
So you have AV concordant, okay, and VA discordant. Ceiling, you have a lot of problem with this.
Yeah, I cannot.
So that is the transposition of great artery. Okay. I wanted to make you to remember. Can you remember that now? So if your atrial ventricle is okay, but the left ventricle is connected to a wrong one, so left ventricle in this situation actually is connected to the pulmonary artery. Left ventricle is connected to the pulmonary artery. What happened in this situation? So this patient has undergone a surgery. So the surgery that the patient has undergone is what we call Rastelli procedure. So basically the LV has been baffled into the aorta. So they have done a baffling, tunneling of LV into the aorta. Okay. And this patient also have a baffle between right ventricle to the pulmonary artery. So what happens is like this. Okay, let me show you, and hopefully you can understand. Okay, so basically this is your heart. That's your heart there. Okay.
Bukan mustard.
Apa dia?
Different. Mustard procedure, not
no, not mustard procedure. No, not mustard procedure. So this like this. Okay. Now, so in this patient, so at first LV is connected to PA. Okay, RV is connected to aorta. So this is LV. So this is RV. Okay. So ceiling okay tak? So you see that LV is connected to the aorta and RV connected to LV is connected to pulmonary artery and RV is connected to aorta. So this is the transposition of great artery. So usually in this situation, you can see a parallel great arteries. If in the short axis view, you can see that the aortic valve is anterior and to the right. So it's anterior and to the right of pulmonary artery. So the aorta is anterior and to the right of pulmonary artery. So far, you understand this one, Sarah and Celine? Sarah?
Yeah.
Okay.
Yes.
So normally, if let's say the patient does not have concomitant congenital heart problem, what they do is they just do a arterial switch procedure. So arterial switch. Switch procedure. Okay, otherwise known as Jatin procedure. Okay, so they do that. So what is arterial switch? They just switch this one. So they bring the pulmonary to the aorta and bring aorta to the pulmonary artery. Okay. However, this patient, okay, when he got this DTGA, but he also unfortunately when he born, he also have pulmonary stenosis. So the pulmonary is stenosed, and he also unfortunately have VSD. So he also have VSD. Okay, so he also have VSD, right? So rather than doing a switch, So what they do in this procedure is it baffle the LV to the aorta, right? And then the RV to PA, they put a conduit, a homograph, a conduit including a valve inside the conduit that connected to the pulmonary artery like that. So this one that you see, my arrow here, I just showing you the baffle from the LV to aorta. So that's the baffle from the LV to aorta here. Now the PA here is stenosis. So what they do is they have, you cannot see, it's very difficult in echo. There's also RV to pulmonary artery conduit. So what you see here, right? So this is LV baffle to aorta. All right. Is that clear, Silly? Why like that? Anything that you are confused?
I mean, if it's normal, how would it look like?
No, normal. This one is aorta. This one going to be aorta. This one going to be okay. So this is, you see that aorta, this pulmonary artery is directly above the LV. This is used to be a ventricular septal defect. So they just baffle through the VSD into the aorta. Okay. So this is DTGA. In CCTGA, you have both discordant. So you have AV and VA discordant. So the LA is connected to the RV and RV is connected to the aorta. So that is CCTGA. We are talking about DTGA, transposition of great artery here. Okay, I've prepared a slides of congenital heart disease and we'll talk about it before. So what happened? So that is what happened here. Okay. So if you look at the next one. Okay. So this also, I just wanted to show you that the LV has been baffled to the aorta. Okay, the LV has been baffled into the aorta. It's there. All right. So this here is the pulmonary artery. Okay, this is the connection. Okay, difficult to show. This is the conduit from the RV to pulmonary artery. We call it a Rastelli technique. So we baffle LV to aorta, and then we do RV to pulmonary artery conduit. Now the reason we do this is because when this patient was born, the patient have DTGA, but with concomitant ventricular septal defect and pulmonary stenosis. Now, if the patient does not have ventricular septal defect and pulmonary stenosis, we just do the arterial switch procedure. We do not need to do the Rastelli procedure. Is it at least a little bit clear?
What happens if you don't do the
procedure?
What happens if you only do the Jatin and leave the VSD?
This did now you have the problem because the VSD is big. So now you have the mixing of blood, so the patient will become cyanose. Another reason is, of course, the patient got pulmonary stenosis, so you have two. Not only you have VSD, you also have pulmonary stenosis. That is second problem. Now the third problem, your circulation now is in parallel circulation rather than in series. So your blood masuk to the left atrium, masuk to the left ventricle, okay, and then go to the pulmonary artery, masuk balik to the left ventricle, okay, and then the right side. So it never mix. That's why we have to do the procedure.
Okay.
Sarah, okay?
Okay.
All right. So CCTGA is AV and VA discordant. DTGA is only VA discordant. Okay. So DTGA with PS and VSD post-Rastelli procedure. We have LV baffled to aorta and also RV to PA conduit. Okay, so this is, I show you again, Sailing, Sarah. So this patient, okay, the patient got VSD, okay, and the patient got pulmonary stenosis. So LV is connected to PA, RV is connected to aorta. So what the surgeon do is just baffle the LV to the aorta, baffle the LV to aorta, transected the pulmonary artery and connect RV to PA via a conduit. This is a Rastelli procedure. Is it clear?
Then the Jatin again is
Jatin,
also...
because there is no VSD and there is no stenosis, right? They just change the place. They cut the aorta and put there. They cut the pulmonary artery and put in front.
Oh, okay. But this one they don't cut, is it?
This one they don't cut. They don't cut. They just baffle the LV to aorta and RV to PA conduit. So of course they cut the outflow because it is stenosed, but from they change the outflow with the conduit. This is the gambar.
Baffle means they connect the two.
Yes, connect the two, correct.
All right. Okay.
Okay. All right. So because you're happy with this question, we look at the next one. So this is question number 7. Okay. So look at this structure here. Right. So this is a parasternal long axis view of someone. Okay, parasternal long axis view of someone. So basically that's the LA. Okay, that's another chamber there. That's a vessel there. Okay, I hope you got a clue from the way I asked the question. Okay, now, so you can see that the great vessel is parallel. You can see that this vessel and this vessel, both you can see the valve. You can see the valve there, and you can see the valve there. So it's actually parallel. Okay, that's parallel vessel. Now, you can also see some structure at the back of the left atrium. So that's a bit weird. You have a structure at the back of the left atrium there. Okay, that's not supposed to be there. Okay, so think about it first. Okay, so I go a little bit to the back of the heart. Okay, so you can see the vessel now. Okay, what vessel do you think this is? Sarah, what vessel is that?
Pulmonary.
Okay, how do you know it's pulmonary artery?
Because it's,
So you can see that it branch, right? It branch. You see that? Go down and it branch to the right and left pulmonary artery. Aorta don't do that. Okay. Now, if let's say this is a left ventricle and this is a pulmonary artery, what is this?
pulmonary valve.
No, this is a pulmonary artery. This is a pulmonary valve. What about this on top here?
Aorta.
Oh,
Aorta. So this is pulmonary artery. This is aorta. Okay. So this is your ultrasound probe. See, this is aorta. This is pulmonary artery. Which one is anterior? Aorta anterior or pulmonary artery anterior?
Aorta anterior.
So aorta is anterior in this situation. Okay. So you have LV connected to the pulmonary artery and RV connecting to the aorta. So what is the condition here?
TGA.
Yes, D transposition of great artery. Okay. Ceiling, do you got it?
DTGA is aorta anterior and left.
No, DTGA is anterior and rightward, but that is in short axis view. Here we're looking at the long axis view, so that is different.
How do we know it's L, not D?
You know, remember, L is double discordant. If L is AV and VA discordant, so your atrioventricle is also discordant. In LTGA, this should be your RV, and this should be your aorta. This DTGA, this is your LV, and this is aorta. So the different one, okay, if you look at parasternal long axis view, in DTGA, because this is RV and this is aorta, you don't see the continuum. So you look at the first echo here. Okay, look at the first echo here. You can see that this leaflet here, the mitral valve leaflet, there is a continuity to the pulmonary valve leaflet. So this means that this must be left ventricle and this must be pulmonary artery because there is a continuation here. Okay, so I show you structure at the back of left atrium. So you can see another one that show this is pulmonary artery. It go down and it bifurcate. Okay, that's aorta. Okay, so this is LV connected to the pulmonary artery and RV connected to the aorta. So the left atrium is still connected to the left ventricle, right atrium still connected to the right ventricle. So you have AV concordance. However, in this patient, you have VA discordant. Okay, so this is the transposition of great artery. In parasternal long axis view, the way to differentiate DTGA and LTGA is in DTGA, there's still a preservation of the continuity between the mitral valve leaflet and the semilunar valve. In DTGA, you will see a pulmonary valve go down and bifurcate. In LTGA, this is still aorta, so it won't come down and bifurcate. This is in long axis view. Okay, in short axis view, normally DTGA is aorta anterior to the right of pulmonary valve, and DTGA is aorta anterior. LTGA aorta is anterior and to the left of pulmonary valve. Is that okay, Celine?
In a long parasternal view lah.
In the parasternal long axis view. So this patient have DTGA. Wait, I will explain to you a little bit later.
What is the small structure at the back? I mean, at down here.
Okay, so I'll just that's the one I want to ask you a question. Okay, so that's the pulmonary valve. So bifurcate. All right. Okay. So what you see there, okay, is actually a baffle. Okay. What you see here, down there, this is a baffle. So this patient is okay, our first patient is DTGA patient that has undergone Rastelli procedure. However, this is an older patient that has undergone mustard procedure or sanding procedure. Okay, so you have a baffle there that reroute the blood. Okay, so what happened here is that, so you have a patient, okay, that have problem. Okay. Right. So this is the PA. This is the aorta. So what happened is they have put a baffle to reroute the blood that come back to the right atrium into the left ventricle and reroute the blood that coming into the left atrium into the right ventricle. So this patient have a baffle. This is what we call a mustard or sanding operation. Is that okay, Sarah?
Yeah.
So if you look at the back here, okay, I'll just show you. Okay, so this is a SVC and IVC baffle. So this blood is actually bringing blood from the right side of the heart into the left side of the heart. So I'll show you back. This is better. Okay, this is better. Look at this. Okay, ceiling. So look at this example. So here, this is left ventricle. This is right ventricle. Okay, so the left ventricle is connected to the pulmonary artery. Right ventricle is connected to the aorta. So what happened in this patient is they baffle the blood. So you can see this one, the posterior part is the baffle. So there is a baffle of blood from the superior and inferior vena cava into the left ventricle, so that it can be oxygenated via the pulmonary artery. Okay, and you can see here in this picture in the middle. Okay, you can see the baffle flow from the SVC going into the left side of the heart. Okay? Another one from the SVC going to the left side of the heart. Okay, that's the baffle. So that is the SVC baffle. Here that you see here.
Why this is left side? This is not right side. This is
so this is left.
punya.
No, this is no normal. So this is left side. Sorry, I salah. This is left side. This is right side.
Right side, yeah.
Sorry, my mistake. So this is the left side. This is the right side. Okay, so this is a pulmonary vein baffle going into the right ventricle. So you have a pulmonary vein, go to the left ventricle and go to the pulmonary, go to the aorta. All right. Go to the right ventricle and go to the pulmonary artery. Right ventricle, go to the aorta. Sorry, I also dah pening dah. So one more time, left ventricle, right ventricle, left atrium and right atrium, left ventricle connected to the pulmonary artery, right ventricle connected to the aorta. So that's wrong. So what they do is they baffle the blood. So oxygenated blood come back to the pulmonary vein. So this left side come back to the pulmonary vein, rerouted to the right ventricle, and then go to the aorta and send to the body. All right. And then in this situation, you have a blood coming from the SVC and IVC going into the right ventricle, because SVC and IVC is deoxygenated blood. So going to the left ventricle and then go to the pulmonary artery and get oxygenated. So this is a baffle. Yeah. So this is the patient that have not LTGA with double switch procedure, not LTGA with relief pulmonary stenosis, not LTGA with switch or steady procedure. This is patient with DTGA and atrial switch procedure. Okay, so this is it. All right. So I mean, at least even though the echo is difficult, do you understand the concept or not, at least?
Yeah.
Really?
I got a question.
Yes.
In TGA, they will have systemic RV, right? So when
if you say you have what kind of TGA you're talking about? Both are right?
Both, right?
Yes, correct. So if you have, okay, let's talk about it a little bit. Okay, let's let's talk about it a little bit. Okay, let's just do it once and foremost. Okay, so whenever you assess morphological heart in congenital heart disease, right, you have to look at atrial level first. So what you do is you look at the atrial level first. Okay, so you look at the atrial level. Okay. So you look at the atrial level first. Is this LA? Is this RA? Is this LV? Or is this RV? So if we say this is LA, that is RA, that is correct. That is called situs solitus, correct. Okay. Now if this is LV and that is RV, that is also correct. Okay. So what you have is atrioventricular concordance. Now in patient with DTGA, unfortunately, you have ventriculoatrial discordance. So this is the left ventricle. Unfortunately, here is pulmonary artery. This is right ventricle. Unfortunately, here is aorta. Right? So far, okay or not?
This is DTGA.
This is DTGA.
All right.
Okay. So what happened is that before this, before modern 1980s, the patient, they can only do palliative procedure, because if let's say you are born with this kind of heart, you cannot survive because the heart does not mix. So this one stay, go to the aorta, come back to the right atrium, and then go to the aorta back. This one go to the lung, come back to the left ventricle. So the patient cannot live. So you have to correct it. So the first operation that they do before 1980s is called mustard or sanding procedure. So in mustard or sanding procedure, what happens is that the blood is rerouted. Okay, the blood is rerouted. So if let's say this is your heart there, let's say you do simple one only. Okay, this is 4. So the blood that go into the right atrium is rerouted to the left ventricle. The blood that go into the left atrium is rerouted into the right ventricle. The blood that go into the right atrium is rerouted into the left ventricle with a bevel inside the atrium. So this is what we call atrial switch. So this is mustard, which is using pericardial tissue from animal. Sanding is using our own atrial tissue. So this is atrial switch procedure. So this is before 1980s, right? Now after 1980s, what they see is they can actually just tukar tempat. They just take the aorta and bring into the PA side and bring the PA into the aorta side, therefore correcting the abnormality. Okay, that is what we call arterial. You see the difference? Arterial switch. Arterial switch procedure or Jatin procedure. Okay, now in our case just now, before one, the patient unfortunately also have concomitant ventricular septal defect and pulmonary stenosis. Therefore, they cannot do straight arterial switch. What they do then is Rastelli procedure. So what is Rastelli procedure? Now, because of the ventricular septal defect, they reroute the LV to the aorta via the VSD, and they put an RV to pulmonary artery conduit. Okay, that's another one. That is called Rastelli procedure. Okay. Now, if you're born now in 2020 with DTGA, you no longer do this procedure. Okay, the problem with this procedure is you are keeping your right ventricle as a systemic ventricle. So you don't want this one. Okay, so all of them will undergo either one of this. And if there is no associated defect, they will do Jatin procedure. If there is associated defect, they will do Rastelli procedure. Am I clear?
Yeah.
Okay, so this is DTGA. Now, the problem with the other one is what we call CCTGA or LTGA. So that one is AV and VA discordant. So the problem is basically that the ventricle change side. Okay, the problem is the ventricle change side. So you have LA and RA. So that is normal. That is situs solitus. However, here you got RV. And here you got LV. And here normal. You got aorta. And you got PA. Right? However, if you notice now, LA is wrongly connected to RV. And RV is wrongly connected to aorta. So you have double discordant. This is discordant. And this is also discordant. So this is called, so you have AV and VA discordant. This is called transposition of great artery. Okay, so far clear?
CC, right? CC, right?
CCTGA, sorry, CTGA, my mistake. Sorry, CTGA, my mistake. So this is CCTGA or LTGA, this one. Understand or not?
Yeah.
Okay, right.
AV and VA discordant, right?
Yes. So in DTGA is only VA discordant. In CCTGA it is AV and also VA discordant. Okay.
VA meaning ventricle and the
arterial.
aorta.
No,
arterial.
A is arterial. So aorta is pulmonary artery, is a group that we call the great arteries. So VA, A is arterial, arteries. So the great arteries. Okay, not Celine. Sarah, I really hope you understand, because at least you understand this. I feel good. Okay, so we see one more, we see the case. Okay, so this patient have DTGA with atrial switch procedure. So we can tell that this is DTGA from long axis view. Now in long axis view, sometimes you can confuse DTGA and LTGA. Sometimes you can confuse the two. So how do you tell the difference between the two in long axis view? Number one is, you know that pulmonary artery will come down and bifurcate. So if they say you look at the vessel that come up from this ventricle, right? This ventricle, right? You see the vessel is come down and bifurcate. Straight away, you know that this is pulmonary artery. That is one. Number two, you look at the continuity between the left ventricle and the valve. So you see this ventricle here, you see the continuity between the anterior mitral valve leaflet and the valve here. If there is continuity meaning there is smooth from here to here, meaning that this must be left ventricle and this must be pulmonary artery. If this is RV and this is aorta, like in CCTGA, you won't see a continuity. I will show you the example a little bit later. But in short axis AOPA view, normally DTGA aorta is anterior and to the right. In CCTGA, aorta is anterior and to the left. Okay, so this is a LDG. Okay, so in how we can see parallel this vessel, but this can either be DTGA or LTGA. The clincher is the fact that the mitral pulmonary continuity is preserved and the vessel coming out from the LV turn down and bifurcate. So this can only be the pulmonary vessel. So the last images shows both the systemic and pulmonary vein baffle. Okay, I won't ask you a question. So this is another example of patient with DTGA. So this is so in this patient, this is LV, RV, LA, and RA. So what happened here? They're baffling the blood from the pulmonary vein into the right ventricle because this patient have. Wait, oh yeah, now that finally it stopped. Okay, so this just while waiting for it to come again. So this is pulmonary vein baffle going into the right ventricle. So wait, I just restarted. Okay. Share screen. So where is now? Baffle. Okay. Can you see the slideshow now?
Yeah.
All right. All right. So this is another. So this is another patient. Okay. So you can see that this is RV. So this is RA. This is actually a SVC baffle going to the left side of the heart. So you can see that the SVC baffle going. So red is towards. So red towards. So this is SVC baffle. Yeah, I show you just example of a baffle. Okay. So we finished with baffle. Thank God for that. All right. What am I showing here?
I just one question. Just now the systemic RV, right? So
Yep.
when you have a systemic RV, when technically we want to measure PAP, right, estimated pulmonary pressure,
correct.
You will also measure in the RV, but it is actually LV pressure, kan? I mean,
yeah, it's just terbalik. Okay, so let's say you are doing you are patient with a mustard or sending procedure. So in order for you to calculate the pulmonary artery pressure, now you have to calculate from which ventricle that is connected to the pulmonary artery. So if let's say the left ventricle that is connected to the pulmonary artery, so you have to look your jet not from the TR jet but from the MR jet.
Okay, right.
Okay,
so
because
the other way around, shouldn't
the other way around.
Go routine stuff. Okay.
Yep, correct.
Can I ask something?
Yes.
You talk about Fontan, right, last time?
Yep.
LTGA, they do Fontan, right?
So LTGA, you can either leave it alone, okay, because LTGA, you have a correct physiological circulation, and then just correct the associated defects such as VSD or pulmonary stenosis. The other two is you can do what we call a double switch procedure. Okay, you can do a combination of mustard sending plus the arterial switch procedure. But if we cannot do both, we think that the patient have like one big and small ventricle, we can go through a Fontan pathway. I will give you like another one teaching just on this complex congenital heart disease. I wanted you to understand the different, at least the basic difference between L and DTGA. Okay. Okay. So what am I showing here?
Yes, your coronary artery.
Okay, so that's the coronary artery. I just wanted to show you. A lot of people don't realize where is the position of the coronary artery. So the right coronary artery, if you look at the short axis view, that's the right coronary artery there. It is actually at the commissure between the non-coronary cusp and right coronary cusp. So if you have if let's say you have your Mercedes-Benz sign like this, right? You have that right like that. Okay. So you have so that's the interatrial septum. So you have like this. Okay, so where does the coronary artery done? So the left usually in the middle of the left cusp like that. Okay, if you say you wanted to see, the right usually come just at the junction here between the. So this is the right cusp, this is the left cusp, and this is the non-cusp. So that is where your coronary artery will come from. You can see this is a left and that is right coronary artery, just in case you want to find. And another thing, this is much easier to see in babies. So that's why in baby, they show you coronary artery quite often when you do echocardiogram because it's easy. And you can also look whether there's any anomalous coronary artery by using this kind of way. Okay, so I just wanted to show you where we can see the left and also the right coronary artery, okay, in echocardiogram. All right, so what do you think about this? Any taker? A bit difficult, but just in case you can see some abnormalities, okay? I just tell you that the abnormality got something to do with coronary artery. Okay.
Coronary fistula.
Okay. This is quite difficult, but what do you think here? You can not the big one. You can see, right? There is a vessel here. Wait,
Coronary pulmonary fistula.
No. Okay. You see this red thing here? Nampak tak? Okay. So red is what? Red is toward the probe, right? So the flow is from here going towards here, correct or not? From here going towards there. From there going towards there. So what vessel you see here normally?
Left coronary artery.
Left coronary artery. What vessel do you see there?
Right coronary artery.
So what is happening here?
Connection between two.
Okay, so you see, so basically what you see is this is the right coronary artery, right? This is the left, right? This is actually a right coronary artery that actually come from the left side. This is anomalous coronary artery. You can have right coming from the left and left coming from the right, right? In anomalous coronary artery. Do you know that, Celine?
No, again?
You can have anomalous. You know that the common cause of sudden death, the number one is hypertrophic cardiomyopathy. Number two is anomalous coronary artery. So you can either have left coming from the right coming from the left. That is one of the variation. You can also have, for example, no right circulation or double left. But the common one is left coming from the right or right coming from the left. This is an example of someone that have right coronary artery that originate from the left sinus rather than originate from the right sinus. You can see that this is the originate going to the right. So this is a right coronary artery coming from the left sinus. Okay, that is anomalous right coronary artery coming from the left. This usually is a benign condition. Okay, you don't need to do anything. Okay, anomalous left coming from the right, you have to be careful. This is right coming from the left. Okay, I just wanted you to realize that sometimes you can see in echo. Don't forget to look at your coronary artery. This is right coming from the left. Any question for anomalous coronary artery? Right coming from the left? No.
It is also considered interarterial, right?
No, right coming from the left is okay. Doesn't matter where it goes through. Usually we don't do anything. Okay, left coming from the right, then we decide, is this interatrial? Is that intramural? Is that retroaortic? Okay, if it's interarterial, left coming to the right, then you do surgery. Other than that, you only do if, let's say, you have evidence of ischemia. Right coming from the left is very controversial. For now, what I know is the consensus, you don't do anything for right coronary coming from the left.
Alright.
Okay, maybe we can do like, some discussion, maybe next time when we do this, we discuss about the anomalous coronary artery. I think maybe I will do one talk about this. I'm also not very good about anomalous, but, Silik, okay? Sarah, okay, yeah?
Okay.
Next. So this is anomalous RCA from the left sinus. Okay, what do you think about this? What structure do you see here, Siling? This is 3D TEE. You want to try or you want to be Sarah?
You wrote that aortic valve.
Okay, aortic valve is at the front. Okay, whenever we do a transesophageal echocardiogram, when we look at the mitral valve, we have to change the orientation so that the aortic valve is at 12 o'clock position. So the aortic valve at the front here. So if they say that is aortic valve, what is this? What
mitral valve.
So that's the mitral valve. Okay. So what is happening to the mitral valve, Sarah? What is the structure at the top here?
Like a ring like that.
Yeah, that's mitral valve ring. So in this patient, what happened is this patient have dehiscence of the mitral valve ring. So the patient have previous mitral valve repair. Whenever you have repair mitral valve, you have to put a ring, right? But the ring has been dehisced, dah tercabut. Okay, so it has a big regurgitation, paravalvular regurgitation. So need to be corrected lah. So if you don't know ceiling, so this is patient in TEE, we can see mitral valve very clear. So when we do a zoom picture of the mitral valve, usually what we do is we will rotate the video, the image such that the aortic valve is at the 12 o'clock position. This will be this will be your lateral part. That will be your left atrial appendage part. This will be your interatrial septum part. Okay. So mitral valve anterior, posterior mitral valve leaflet. So this is the ring that has this. So this patient go for surgery.
The BG is the ring, is it?
That is that is the suture, place where they suture it. Okay. So after they have repaired the valve, they notice this. Okay, what is your diagnosis? So this is the left ventricle, right? This is the left atrium. Left ventricle, right, left atrium. What's the diagnosis?
LAA thrombus.
Okay, what do you think? Is it LAA thrombus, Ceiling? Do you agree with Master Solomon?
I will just agree.
Okay. So this is actually, I thought this is an abnormal mass, So this is actually amazing. You know what is this or not? Okay, let's say I go and change you this one. So TE show mass in the left atrium. Okay. And then this is the 3D TE. Okay, now you look at that. So this is the mass. The mass comes from the left atrial appendage. Does it look like thrombus to you or not? So there's a mass there that coming from the left atrial appendage. What do you think, Sarah, now?
Watchman, I don't.
So this is an amazing case. You know, right? So if you have heart, so let's say this is your heart, then you will have a left atrial appendage coming out like that. Or not? For some reason, the surgeon, when they do the operation, what the hell did I do?
Like it.
Not like it. When they do the operation, okay, like this. Dia terbalikkan the left atrial appendage. It's like your kain, and then you terbalikkan. Dia tertarik the LA appendage inside the left atrium. Dia tertarik macam your socks, right? You tarik inside the left atrium. So what they do is they just put it back inside.
So what will happen?
No, nothing happened. They just put that back inside. Yeah. They tertarik, then they just put, like your socks, right? Yeah, like you see, this is my glove. And then dia tertarik, terbalik, tarik like this. That's what you see. So what the surgeon do? The surgeon just tolak balik.
So it doesn't cause anything lah.
Doesn't cause anything. Yeah.
All right.
So next time you see that, don't cemas. It's not tumor or anything. Sarah, you agree or not?
Yes. I mean, how to confirm that? Just by
TE, they actually confirm it with TE. They look at the TE, right? They look at TE and say like, that is look like LAA appendage terbalik.
Nice,
from the 3D view. So this is an amazing case of inverted left atrial appendage. It is another case.
Can we see that again?
Sure. You want to see the 2D view or 3D?
2D lah, 2D. 3D I bodoh.
That's the 2D view.
So they just push up the
They just
the
pull,
LAA appendage.
correct. Then they just push back down.
Okay. Sometimes they ligate the LAA appendage also.
Correct. Sometimes they ligate the LAA appendage also. Okay, let's look at another case. Okay, look at this echocardiogram. Okay. So this is a parasternal long axis view. Is there any abnormalities that you can see?
Yeah, doming of aortic valve.
Okay, so what do you think is the diagnosis?
Bicuspid aortic
So
valve.
possible this is a bicuspid aortic valve. Okay, let's look at the next picture. Right. So what does the patient have?
AR and AS.
Right, yeah. What do you think is the AR severity?
Severe.
Yeah, severe aortic regurgitation. Correct. Okay. Right now, look at this echo. Now this is the patient aortic valve. So what's your diagnosis?
Vegetation.
No, look properly at how the aortic valve open.
Oh, there's a windsock. Is that a windsock?
No. Look at the aortic valve. Ayo, it's a lot of different diagnoses. The one that doesn't exist. So what is the diagnosis? What kind of valve is this?
Quadricuspid.
Quadricuspid.
No. Kena tekan. I cannot. So basically, if you notice, you see like a bullet like this in the middle. Okay. You see, I put the bullet here in the middle, and then play back during the opening. Okay, you see the bullet opening. So the bullet. So this is actually unicuspid aortic valve.
Oh, okay. Unicuspid meaning?
Meaning that there is only one leaflet. One leaflet surrounding it. You can see when it opens. So
what is the top one?
This is Refi. Oh. So what happens is like this. Okay, so I show you. It's quite interesting. Let me show you. So when it opens, so it okay. So when it opens, so this is your valve. All right. So what happens is like this. Okay, when it opens, okay, it's open like this. Okay. That is on the opening. So what you see there is actually two Rafi like this. Okay, but it's actually the Rafi doesn't separate. So this is the hole that you see. So this is a single leaflet. Okay, this is just a Rafi. So now that you see that, see it again, and then familiarize yourself. Okay. Does it make sense now? Okay. So all this here is a single valve, and then it open here. That's a single opening. Now, in a patient with bicuspid aortic valve, it should open like this. It should extend to the rest of the heart. And this hemi-elliptical. That's how bicuspid aortic valve. Okay, and bicuspid aortic valve usually only one Rafi. In patient with tri-leaflet, it will open like this. Okay. This patient is open like this. Very weird. Open like that. Okay, open like that. And then after that, the patient got Rafi here. I even tunjukkan for you like this. Alien in the middle.
The bicuspid one, where is the Rafi?
The bicuspid depends. So the bicuspid, if you have like this, so if you have, let's say you have like this, so you have bicuspid like that, depend on which commissure that is. So let's say it is between right and none, then you have Rafi like this, satu. So only one. So this and this. This. Okay, if they say it's between, for example, left and right, then the Rafi is going to be between here and here, like this. Okay, so this is a unicuspid aortic valve. Okay, that's unicuspid aortic valve. Okay, so is it clearer here now?
Yeah.
Okay. So this is a unicuspid aortic valve. Okay, I just wanted to ask you all, what leaflet is this?
Bicuspid.
Yep, which leaflet? Sarah, I will expect you to know this is bicuspid valve. Okay, if you don't know this bicuspid valve.
Anterior.
That's very good. That is the anterior leaflet of tricuspid valve. That is posterior leaflet. Most of the time, it's anterior, is posterior. If you see it is just one long leaflet, that is anterior leaflet. If we see two leaflet, that's anterior and posterior. If you see LVOT start coming in here, then that is become septal leaflet, and that's posterior leaflet. Okay, very good. What is this structure here, ceiling?
Yeah, again. What is that structure? Oh, left coronary artery. No.
No.
RAA.
Apa dia, Sarah?
RAA.
Bang, this is what structure here.
Right there. Oh, LAA. Sorry.
Yeah, this is left atrial appendage. That's LAA, RE. So that's the left atrial appendage. Okay, good.
Where exactly it is?
This one. Semua pun nak kena tunjuk. This one.
Oh, okay.
Okay. Right. Okay, what about this one? Okay, this is quite easy.
Oh, ball. This is a thrombus.
Does thrombus look like, okay lah, maybe thrombus. That is actually, what is that? Ceiling, you want to guess?
I don't know, vegetation.
No, that is actually the, the Untitled occluder device that you put for ASD, atrial septal defect. Actually, embolus. Embolus to the left ventricle. They managed to operate and take it out, but this is, this embolus of the Untitled occluder device, number 14.
Oh.
All right. Okay, so this one is actually, I don't want to ask you all because this, I think, what this case supposed to illustrate is someone with severe tricuspid regurgitation. Okay? And when you look like this, the leaflet look retracted. So you will say that maybe the TR is because of RV dilatation. However, when they do the 3D echo, they wanted to illustrate the importance of 3D echo. Okay, this is the RV inflow. Still, they don't know what is the reason the patient have tricuspid regurgitation. Okay, now it's not very clear. So when they do a TEE 3D, okay, so what happened is that this is the utility of 3D. So this is actually I think this is the posterior leaflet of the tricuspid valve. Okay, that is the anterior and that is the septal leaflet. So if you can see there, right? If you can see, there is like a okay, this one. So this one. Okay. All right, this one. So apparently, this is a flail posterior leaflet of the tricuspid valve. So the patient actually have a flail posterior leaflet of the tricuspid valve that's only clear on transthoracic echo 3D view. So just wanted to illustrate the utility of 3D in diagnosing things that really difficult to diagnose. Okay, so just wanted to show you that it's possible actually to have a flail of the tricuspid valve leaflet. I couldn't really explain more about this one. So I'll find it a bit confusing, this one. So let's go and see the... Okay. All right. So look at this. And this is left atrium. This is left ventricle. This is flow across the left ventricle towards the left atrium. Okay. So what do you see here?
Double jet.
Double jet. So if you see double jet like this, right? What do you think about?
This is the apical hookum.
Yes. So one of the things is apical hookum, right? You have the apical hookum with pouch. So if you have apical hookum with pouch, you can see systolic and systolic flow and also diastolic flow. But the problem with this is, okay, so this is your end diastole, okay, this is end systole. You notice or not? This flow is not diastole. Betul tak, Sarah? So this is not the double flow. Okay, so this is a normal MR. So there's nothing abnormal about here. This normal MR, but you see something here. What is that?
That's a diastolic MR.
So very good. So this patient have a diastolic MR. Now looking at the Doppler here, what is one of the reason that you can have diastolic MR? Severe IT regurgitation, correct. So, but this patient does not have severe IT regurgitation. But the clue of the diastolic MR come from the ECG. What's the patient? Not complete. PQRS. This patient have severe first degree heart block.
Oh, like that.
Severe first degree heart block. So apparently, one other reason of diastolic MR is severe first degree heart block. I don't know what is the reason. So maybe that can be a homework for both of you. And then when the next time we discuss, you can tell me why patient with first degree heart block can dapat diastolic MR. Or maybe you can, we can discuss together what is other causes of diastolic mitral regurgitation. Okay, so this is a patient with diastolic MR secondary to first degree LV block. Okay, that's the diastolic MR there, secondary to LV block. So happen at diastole. All right. So this actually, okay, I just wanted to tell you, this is a pulse Doppler across the pulmonary valve. Okay. So this is a pulse Doppler across the pulmonary valve. Pulse Doppler across the pulmonary valve. So this is during systole. Okay. What abnormality that you see here, Saravanan? So this
pulmonary vein reversal.
No, this is pulse Doppler. So this is across pulmonary valve. So let's say you have pulmonary valve, right? That's your pulmonary valve. Then you put a pulse Doppler here. Okay, so you got this image here, right? So what is the sum of abnormality? So do you expect this? So this during systole is a forward flow, right? So what are the abnormality that you see?
Second forward flow.
No, you also have a second forward flow, right? And this forward flow happen in what phase of the cardiac cycle? You have a second forward flow. So this is a normal forward flow. This happened during diastole. Okay, it happened, but sometimes it happened, but sometimes it doesn't happen. So you have this, it happened here, but it happened here, but in the middle it doesn't happen. Okay, so apparently, okay, this is another one that is interesting. So apparently this patient have constrictive pericarditis, and during inspiration, because there is a lot of flow going to the right side of the heart, the right side of the heart cannot take it, that even on diastole, you have forward flow in the pulmonary valve. So this pulmonary valve forward flow is happen only during diastole. So this is what they call pulmonary artery forward flow during diastole at inspiration in patient with constrictive pericarditis. So one of the sign of constrictive pericarditis. So quite a novel sign. So when you see a flow that is more pronounced during inspiration, forward flow in diastole, think about constrictive pericarditis. This is like something that is new that I just learned. That might come in the exam. You almost finished. Okay. So constrictive pericarditis. All right. So let's look at this one. Okay. Let's look at the difference between this one and this one. Okay, this one. So what do you think happened from here to here? What has happened from here to here?
Severe MR, severe TR.
So this here and here is the same patient. What has happened from here to here?
The MR has improved.
Okay, why? So MR improved, right? Why do you think the MR improved? You think?
Is there a ring?
Why suddenly, like this patient, they can improve the MR just like that, on and off, right?
Blood pressure.
No. So basically, I just wanted to show you that the MR can be dynamic. So in this patient, this is actually when your pacemaker, this patient have a pacemaker. The pacemaker is like in the right ventricle. So when the pacemaker is on, the patient got severe MR because of desynchrony. Because of RV, LV desynchrony, the MR is very severe when the pacemaker is on. When the pacemaker is off, the MR get better. So this is on pacemaker. This is off pacemaker. Okay. So this is MR is severe on the right side because there is pacemaker that is switched on. Pacemaker induced LV desynchronized cause more severe MR. Right. All right. What about, so this is the next one. So this is different case. So look at this echocardiogram and look at the mitral regurgitation. So I just wanted both of you to say the answer can be different. Severity. Is it 1+, 2+, 3+, 4+? Okay lah, maybe just tanya Sarah. Is it mild, moderate, or severe, Sarah?
Severe.
Severe.
Severe. Okay, but
Yeah.
are you sure? Look at the duration of the mitral regurgitation. Is it long or is it very short? Even though the jet itself is big, but what about the duration, you think? Is it long or is very brief?
Brief lah. I mean, it's quick lah.
It's quick, right?
But
So
the color reaches the pulmonary vein.
But how do you, let's say I want to ask you, right? How do you calculate regurgitant volume?
Regurgitation volume.
Regurgitant volume is ceiling, yes.
The stroke volume, the difference in the stroke volume in the right heart and the left heart.
So that's one of the way. Then another way is of course you do your PISA, right? Okay, so EROA times your MRVTI is your regurgitant volume. But this is very brief. Okay, so if I show you the next one, okay, what do you think now? So the Doppler should be full, right? The Doppler should be full because N should be from here to like this.
Okay.
Right or not? Okay. So this is what. So what do you think is the diagnosis here?
Mitral valve prolapse.
So this is a patient with mitral valve prolapse and late systolic murmur. So in this patient, even if the EROA is say 0.4 centimeter squared, okay, but when you times dengan MRVTI, you only trace half. Correct or not? Okay, so the volume is actually less than severe. So whenever you see mitral valve prolapse with a late systolic murmur, always beware. Don't just look at the size of regurgitation. Okay, also look at the length or the time it takes for the regurgitation to happen. Okay, is it okay, Saravanan?
So will this be severe?
Nope. Usually late systolic MR is almost never severe. Late systolic MR is always almost severe. And you also remember, right, like mitral valve prolapse, remember that it is called a click murmur syndrome. Ingat tak?
Yeah.
It is called, why click murmur? We call it click murmur because at early systole, when the LV contract, the chordae tendineae become taut. And when become taut, you have the click. And then after that, the murmur is late. So click first, and then after that, murmur. So that is why we call it the click murmur syndrome, the mitral valve prolapse. So whenever the murmur is not holosystolic, the color will tend to overestimate the severity. So this can also happen in functional MR occasionally when the flow is maximum at the beginning and end, but not in the middle. So always look at the color Doppler flow first before you decide whether something is severe or not. Okay, so this is a Doppler across from the apex. Okay, so let's say that I show you that a Doppler, and this Doppler is across the apex of the left heart. So what is happening here, Saravanan or Siling?
Velocity is 6.
Very good. So velocity is 6. So what kind of Doppler? So is this aortic regurgitation, aortic stenosis, mitral stenosis, mitral regurgitation?
Wait, let me think first. It's high, right? The velocity.
Yes, correct. It's high the velocity, pandai.
So it has to be aortic stenosis.
Are you okay? I show you. Okay, one of the trick. So this is the diastole. Okay, now this is where is this systole?
Okay.
Maybe that is like systole or something like that. Okay, now you see isovolumetric contraction and isovolumetric relaxation. Okay, this flow also comprise isovolumetric contraction and isovolumetric relaxation. If they have aortic stenosis or LVOT obstruction, it won't comprise the isovolumetric contraction and isovolumetric relaxation. So this is a mitral regurgitation. Okay, MR. MR is high velocity. Is that clear, Sarah?
Yeah.
Okay. Just showing you this also, can this one. All right, so that is where you do. All right. So that is actually a mitral regurgitation Doppler. All right. Now, if I show you this echocardiogram, and I show you this Doppler, okay? So this is actually the mitral inflow across from mitral valve to the left ventricle. Choose what do you think is the ejection fraction of this heart. Is it from between 20 to 40%? Is it between 40 to 60%? Or is it between 60 to 80%?
That the flow is across the mitral valve.
Mitral valve, yes. I'm sure you won't know. I also don't know this one.
40 to 60.
Okay, so
is it
basically this is something that is novel, you know. So you know, right, when you look at your mitral inflow, you want to see E or A wave, right? Correct or not, Sarah?
Yeah.
So you would think that this is the E wave and this is the A wave, correct?
Yeah.
Right. So I also thought that is correct, and this is the L wave. Okay. Now apparently this is actually not the E wave. Okay. So what happened here is, if you look properly, this one is actually happened during the isovolumetric relaxation. Okay, during the IVRT, not during the early diastole. So actually this is the E and this is the A. Okay, and you have this flow during the IVRT. As apparently, if you have this IVRT high flow like this, it means that your LV is very hyperdynamic. So if you look at the echo here, so the LV is very hyperdynamic. Okay, so if you have hyperdynamic left ventricle, they say you can see a suction flow here, not at early diastole, but at isovolumetric relaxation. So basically, if you look at this E wave, just make sure that it is early diastole rather than isovolumetric relaxation. So if this one is like something that is special, that is very rare, that shows someone with hyperdynamic left ventricle, this suction during isovolumetric relaxation. Okay, so I think you can just take picture or what. Just remember this picture.
Wait.
It's good or not good? Good lah. Athlete side lah.
No, athlete where got hyperdynamic. Athlete is really dilated. It's quite dilated. They pump a little bit. Already stroke volume is good. This one I think I don't know. Maybe the patient got like very severe left ventricular hypertrophy, small cavity. I don't think this is good.
What is it called? What sign? Anything?
No sign. Saravanan sign. You put your sign. Saravanan sign. I want to put this Saravanan sign. Okay. So this answer is 60 to 80%. All right. So just two more. Okay. So this wave is at the IVIT. This is not the E wave. This is a special situation in greatly hyperdynamic heart, whereby there is suction effect during the isovolumetric relaxation time. So question number 22, this is a 52 years old female, have click and murmur on physical examination. So what is your diagnosis? Mitral valve prolapse, correct. Okay. Now, have you ever heard of Pickel-Hobby sign? Pickel-Hobby sign.
The crown.
So basically Pickel-Hobby sign is the German army punya helmet, right? So this Pickel-Hobby sign basically show very fast movement of tissue in the wall of the Doppler I show you now. Okay. Special to mitral valve prolapse, sudden pulling of the chordae during systole causing clicking and then murmur. So the sudden pulling of the chordae on the posterior papillary muscle causes the adjacent muscle to move quickly towards the apex. This is called a Pickel-Hobby sign. So you see what is this or not? So do you see this one? So that's anterior mitral valve leaflet. That is posterior mitral valve leaflet. Okay. So this patient have mitral valve prolapse. So what happens is this is chordae tendineae. Okay, the chordae tendineae, okay, is pulling the prolapse is pulling the papillary muscle very, very forcefully downward, cause the opposite motion of the wall to that side. That is very fast. Okay. So apparently, if you put a tissue Doppler here, you will see that Pickel-Hobby sign. So they call this the tugging of the posteromedial papillary muscle in mid-systole by the maxomatous prolapsing leaflet causes the adjacent posterobasal LV wall to be pulled sharply towards the apex. The problem is the forceful tugging may serve as a trigger to generate PVC, non-sustained VT or polymorphic VT associated with sudden cardiac death. So this Pickel Hobby sign is actually a marker for increased risk of sudden cardiac death. So I show you after this. Okay, so this is it. So if you put Doppler at that wall, you will see this sudden spike, and apparently this look like a orang Jerman punya topi. Okay, that's the topi. That is called Pickel Hobby sign. So the velocity is high, more than 16 centimeter per second. It is an indicator of malignant phenotype of myxomatous mitral valve disease and bileaflet mitral valve prolapse. It shows that your patient might be at risk of ventricular tachycardia or ventricular fibrillation. So this is most common in young women. So if you ever seen Pickel Hobby sign, so ceiling, you might teach Li Hongbang this if you don't know.
Can I ask something? This is tissue Doppler at where? Which
at lateral
side?
wall? At lateral wall. So you can, there's few sides you can do. So you can either do, so let's say this is a 2-chamber view. Okay. So you can do this side where the insertion of the papillary muscle. Okay. Or if this is a 4-chamber view, okay, you can also put that side at the adjacent to the papillary muscle. So that's where you do it. I show you.
This is TDI lah, TDI.
TDI, yes, TDI, correct.
At the right ventricle lah.
Left. So this one left ventricle, right? You
Left,
do here.
right.
Left at the insertion of the papillary muscle.
Okay.
Left ventricle.
Right. So it's not at the annulus.
Not at the annulus.
Up there.
Yes, here where the papillary muscle insert here.
Oh, okay.
Okay. And you can see this late systolic Doppler that is typical of mitral valve prolapse. Okay, late systolic and click and murmur. Right. So again, you can see also this patient also you can see this move suddenly, boom, move suddenly, poof. Okay, because of the tugging of the mitral valve chordae. Right, this is an example of an M mode of mitral valve prolapse. Okay, this might come in your exam. I expect you all already know that. You can see that's showing the mitral valve prolapse there.
How?
See this one. Look at this. So this is the M. Okay, and then suddenly it go down there. Usually it's supposed to go here and close, but this one it go down here.
Okay.
So that is example of exam. Right. So this again showing you put a tissue Doppler there. All right, and this is the sign. Okay, Saravanan, tell me what is the name of the sign again?
Pickel
Hobby. I don't know how they pronounce it. But it's a Pickel Hobby sign. Right, so this is a Pickel Hobby sign or mitral valve prolapse. Okay, so this is our last case. I will just go through this because I have to get my vaccination in 15 minutes time. All right.
Wow.
All right. So what I wanted to show you here is someone with situs inversus totalis. All right. So basically, I will teach about you a little bit about it later, next time. Okay, but the relationship between aorta and pulmonary artery is very important. Okay, so in this short axis view here, you can see that this is a normal relation of great artery when you have aorta here and you have pulmonary artery on the left side there. However, when you look at the subcostal view, so this is the liver, you can see that the liver is on the left side, not on the right side. So that is wrong. So that is what we call situs inversus. Now, the liver and atria always follow each other. If they say the liver terbalik, the atria is also terbalik. You can see that the LA is on the wrong side. So the LA is on the right side and the RA is on the left side. So this is what we call a situs inversus. Now, if they say a situs inversus, in which the apex of the heart is pointing towards the left side, that is just a normal isolated situs inversus. However, if the apex is also pointed toward the right side, so this patient have dextrocardia and opposite side of the liver, this is called situs inversus totalis, where the LA and RA is change side, the liver change side, even the visceral organ also change side. So your left lung become your right lung become your left lung, and then your descending colon change from the left side of the abdomen to the right side of the abdomen. So that is what we call situs inversus totalis. You can see RA on the left side and LA on the right side. The LV and RV is in the correct place. You can see this is RA, LV, and aorta. So this is a wrong arrangement. All right. So again, another wrong arrangement of RV to pulmonary artery. So the patient have normally related great artery, i.e. there is no transposition. The RA and LA is inverted position and the liver is on the left side. So this is a visceral atrial situs inversus. The heart is pointed to the right and there is right-sided aortic arch. The viscera, including the lungs, the colon, will be mirror images in this situation. So this is known as situs inversus totalis, as opposed to just situs inversus, where you have isolated visceral atrial situs inversus with levocardia. All right, guys, thank you very much for staying with me. I know it's so long. I really appreciate it. Thanks. I have to go to rush. All right.
Okay, bye-bye.